Hello, and thanks for the opportunity to present today. I'm going to talk about inequalities in cancer survival by sex. So despite the well-established evidence that sex is an important prognostic factor in several diseases, unfortunately, the role of patient sex is often left unexplored and is even underreported in cancer research. To date, few studies that have addressed sex differences in cancer survival found that men generally have lower survival than women for majority of cancers, but we have limited knowledge about the magnitude of these differences and whether they are changing over time. So in this study, we aim to investigate sex differences in cancer survival using robust data and to explore these differences according to age at diagnosis, time since cancer diagnosis, and year of diagnosis. So all incident on cancer cases were identified through Victorian Cancer Registry. Obviously, we excluded sex-specific cancers, including breast cancer, as it is rare in men. The study cohort comprised of all cases aged 15 to 99 years old, with first primary cancers diagnosed between January 1982 to December 2015. We excluded cases notified through death certificate only or diagnosed on 31st of December 2015, which was the last date of follow-up. We included more than 412,000 cases and analyzed 25 cancer types with at least 1,000 cases. So what is net survival? Net survival is the probability of survival when the cancer under the study is the only possible cause of death. So how did we measure net survival in our study? We estimated net survival by contrasting all causes of mortality of the patients for the expected mortality of a comparable group from the Victorian population. So in this case, we use Victorian population, which is stratified by age, calendar, and age. So it helps us to find out what would be the expected mortality of these patients if they did not have cancer. We also modeled the effect of sex on the excess mortality rate, which is the additional hazard of death due to cancer diagnosis. So you can tell from the formula here that, again, it's a mirror image of net survival, like you see here, observing all cause of mortality in patients to their expected mortality rate if they did not have cancer. So why we use this model as an additional method? Because it helps us to account for other variables that associated with trends and differences in cancer survival, such as age at diagnosis, time since diagnosis, and year of diagnosis. So in the interest of time, I'm just going to show you the results of excess mortality rates. This graph shows survival differences comparing men with women. I don't expect you to read all of these cancers. What I want to highlight here is that this vertical line shows the reference value for excess mortality. So these dots shows the estimates of excess mortality, and these horizontal lines are the 95% confidence interval. So it means that when the confidence intervals touches this vertical line, it means that there is no difference between men and women. Here is the closer shot of those cancers that show differences between men and women. So you can see at the right side of this vertical line, we found that of those 25 cancer types, men have survival disadvantage for cancers such as head and neck, esophagus, colorectal, pancreas, lung, bone, melanoma, mesothelioma, kidney, thyroid, and non-Hodgkin lymphoma. So for example, men had 20% higher excess risk of death for head and neck cancer compared to women. In contrast, melanoma showed the greatest difference for higher excess risk of death for men. So it means that men had twofold higher excess risk of death compared with women. In contrast, women showed lower survival than men for cancers of the bladder, renal, pelvis, and ureter. So we also estimated excess mortality rates by age at diagnosis. We found that for majority of cancers that men have survival disadvantage, a male excess risk of death decreasing with age at diagnosis. So for colorectal cancer, we observed these trends for cases diagnosed after the age of 45. So you can see that between 15 to 44 years, there is no survival differences between men and women, but these trends disappeared by increasing in age at diagnosis. So for most cancers we looked at, there were no survival differences at the age of 75. You can see this is for colorectal cancer, this is for lung and non-Hodgkin lymphoma. Over 75 years old, there is no differences, but for melanoma, although the excess risk of death decreased by increasing age at diagnosis, but still there is a differences among older patients. We looked at by time since diagnosis. It is interesting to see that for colorectal and esophageal cancer, the excess risk of death in men compared with women increases with time since diagnosis. You can see from here, this is the first year of diagnosis and this is the 5th year of diagnosis. So it means that men had higher excess risk of death compared with women in the 5th year compared to the 3rd year. So it means that the gap is larger at the 5th year. We also observed the weaker evidence of this trend for kidney cancer. You can see that the differences increased until the 3rd year and then it started gradually decline from the 4th to 5th year. It is interesting to see that for bladder cancer, a women's survival disadvantage was only evident for the first 2 years following diagnosis. It is unclear for us why these trends are different by cancer type. Here, regarding year of diagnosis, fortunately, we see here that the sex differences for colorectal and pancreatic cancer decrease over time and actually reach to the point there is no differences between men and women in the last 9 years. But in contrast, for lung cancer, you can see here that the sex differences increase over calendar time, although there were no differences in the first 3 periods of diagnosis. Weaker evidence of this pattern also observed for bladder cancer. Regarding increasing survival differences for lung cancer, we decided to investigate further by looking at the trends in the incidence of lung cancer and excess mortality rates by histological time. I don't have time to show you the results, but we found that at least part of this pattern explained by temporal trends in the incidence of lung cancer by histological type. So the strengths and limitation of our study, the strengths of our study is the large sample size, population-based design, and complete follow-up through Victorian and national death registries. Limitation, unfortunately, we didn't have information on smoking status, which is highly correlated with histological type. And we also didn't have access to a smoking-specific life table, which could bias the estimate of excess risk of death for smoking-related cancers such as lung, head and neck, and bladder. We didn't have data on stage of diagnosis, treatment, comorbidities, and health-related lifestyle behaviors such as smoking and drinking, which prevented us from exploring the potential role of these factors as mediators of sex differences in cancer survival. So we know that men have generally fare worse than women for majority of cancers, so why they have lower survival than women? There are several hypotheses. The first one is the influence on sex hormones on immune system and tumor characteristics. Some studies suggested that genes on the X chromosome protecting women from cancer progression or metastasis. Other studies also mentioned that the higher level of testosterone in younger men and middle-aged men contribute to the cancer aggressiveness. The other hypothesis is about the stage of diagnosis. They usually say that men probably diagnosed with more advanced stages due to different reasons. The last one is the sex differences in treatment modalities, comorbidity prevalence, and lifestyle behaviors, but these are highly speculative and they are not proven yet. So why women have lower survival for bladder cancer compared with men? There is a strong evidence that women more likely to be diagnosed at advanced stages and with high-grade tumors, probably because the signs and symptoms of bladder cancers unfortunately misdiagnosed with cystitis and urinary tract infections, which basically means that women have delay in referral to oncologists or urologists. So where do we go from here? It is essential to identify the underlying reasons behind sex differences in cancer survival, which potentially could improve outcomes for both men and women, and hopefully decrease the global burden of cancer. At the end, I would like to finish by acknowledging my supervisors, Professor Dallas English, Associate Professor Rajan Menon, Cancer Council Victoria, and Victorian Cancer Registry, and Australian government for supporting me through research training program scholarship. Thank you very much for your attention.
Thank you again, a lovely presentation. Are there any questions? We've got a couple of minutes up our sleeve. Rather than a question, I suppose I've got a comment. As a part-time lung cancer doc, I'm wondering whether the differences in the male and female death rate in lung cancer is because over the last 10, 15 years, we've seen greater use of EGFR inhibitors, which is more likely to be in a female population than men.
Yeah, so I'm glad that you asked because I have the extra slides to show you here. So we combine all histological types and we saw the differences and which increased over time, and we decided to look at by histological types. So the first three, one is the non-small cell lung cancer and the last one is small cell carcinoma. And interestingly, we found that there is no trend by histological time over time. So you can see that the greatest difference for men had worse survival for adenocarcinoma, and then secondly for small cell carcinoma. Interestingly, that men didn't have lower survival than women for squamous cell carcinoma. So next I'm going to show you the trends in the incidence of lung cancer. And this is what I mentioned, that at least part of the increasing sex differences over calendar time explained by temporal trends or changes in the trends of histological types. So you can see here that this is adenocarcinoma that increased for men, probably doubled, but hugely increased for women, tripled for women. So which could explain, because as I showed in the previous slide, that women had the greatest advantage for adenocarcinoma compared with men. The other thing that this is the squamous cell carcinoma, the blue line, which showed that men and the incidence of this cancer decreased, actually halved for men, which men didn't have worse survival than women. So we think that this one at least explained the increasing survival differences. Yeah.
Thank you. And again, I promised that, but that was not set up. If there are no other questions, we'll move on to the next section. Thank you.